The notion of cellulite was first defined by French doctors in 1922. Cellulite is the unproportioned deposit of fat within the skin that pushes up against connective tissue beneath the skin. Cellulite is a painless skin condition involving aesthetic concerns with dimpling and denting of the skin surface, giving it an orange peel appearance. Cellulite is deposits of fat surrounded by fibrous connective tissue that give the surface of the skin a puckered, dimpled appearance. It's most common in the thighs, hips, and buttocks. Cellulite, contrary to popular belief, is not caused by fat. It's a harmless skin condition that can affect anyone, regardless of weight. About 90% of women will have cellulite at some point in their lives, usually after age 25, compared to just 10% of men. Cellulite is more and more often treated as illness, since as the definition of World Health Organization demonstrates, it more and more often negatively influences a mental state of both women and men. It usually occurs after puberty. Clinically, the topographic changes manifest as dimpling, denting, or nodulation, leading to an uneven surface of the skin. The dimpling gives the skin the appearance of a mattress-like, cottage cheese, or orange peel, which is the characteristic clinical appearance of cellulite. Nomenclature of cellulite. Cellulite is also known as adiposis edematosa, dermopaniculosis deformans, status protrusus cutis, and gynoid lipodystrophy in the medical field. However, in colloquial language, orange peel syndrome, cottage cheese skin, hail damage, and the mattress phenomenon. Etiopathogenesis. The etiopathogenesis and pathophysiology of cellulite have not yet been fully elucidated. Cellulite may be regarded as an architectural disorder of the dermis and the associated subcutaneous tissue. In the gluteal region, where cellulite most commonly occurs, the subcutaneous tissue consists of 5 different tissue layers: the dermis, superficial fat, superficial fascia, deep fat, and deep fascia, and 2 types of fibrous collagenase septa, short, thin septa, and the tall, thick septa. The short, thin septa connect the superficial fascia to the dermis, and the long, thick septa connect the deep fascia to the dermis. The short septa are more numerous than the long septa but are less stable, while the long septa are less numerous but have greater stability. The fat lobules in both adipose layers are arranged in a honeycomb-like structure and are enclosed by fibrous connective tissue, with the fibrous septa interdigitating the lobules. The superficial fat globules are significantly higher in number but are smaller in height and width compared with the fat lobules in the deep fatty layer. Thus, the deep fatty layer is significantly thicker than the superficial fatty layer. An increase in body mass index, BMI, is associated with an increase in the thickness of both fatty layers, an increase in the height of the superficial layer, and an increase in the number of fat lobules in the deep layer. According to the architectural disorder hypothesis, imbalances in the inherent biomechanical forces within the septa, adipose layers, and the dermis contribute to cellulite development. The septa, short and long, impart an inward tethering force, while the adipose tissue layers impart an outward force, and the dermis imparts an inward containment force. As the short septal connections are less stable, they are unable to contain the superficial fat lobules, causing an imbalance of forces and resulting in a dimple being created at the inflexible thick septal connection to the dermis, subdermal junction. In females with low normal BMI, the dimple created may or may not be recognized as clinical cellulite. In females with high BMI, the height of superficial fat lobules and the thickness of both fatty layers increase, exaggerating the imbalance of forces at the subdermal junction, which alters and weakens the subdermal junction, resulting in more pronounced dimples and depressions. Fat may herniate through the long septa. Fat herniation, however, is a secondary event and not a primary cause of cellulite. Males rarely have cellulite, and this may be explained by the gender dimorphism in the fibrous septal network and the adipose layers. While the fibrous septa are oriented vertically to the dermis in females, they are oriented at approximately 45 degrees angle to the dermis and crisscross in males. Males also have more numerous short, thin septa. Further, the septa in males are stronger and more stable than those in females. Females have fewer fat lobules and the fat lobules are greater in height and width. These sexual differences in the number and morphology of fat globules are more prominent in the superficial fatty layer than in the deep fatty layer. Thus, in a given area, males have a greater number of subcutaneous fat lobules and a greater number of septa. Because gender is a primary influencer of the biomechanical forces at the subdermal junction, the female sex hormone estrogen likely plays a pivotal role in the development of cellulite. In addition, high estrogen states, such as pregnancy, nursing, chronic oral contraceptive use, or hormone replacement therapy in postmenopausal females, appear to exacerbate or worsen the progression of cellulite. There are two other hypotheses for the development of cellulite: the vascular hypotheses, and the inflammation hypotheses. The vascular hypothesis. According to this hypothesis, the precapillary arteriolar sphincters in the affected areas are altered, increasing capillary permeability. The combination of increased capillary permeability and pressure on the capillary walls leads to leakage of fluid into the interstitial spaces between the fat lobules and interlobular septa. The ensuing intercellular edema and tissue hypoxia elicit neovascularization and thickening and sclerosis of the fibrous septa, which leads to accentuation of skin irregularities and ultimately the appearance of cellulite. The inflammation hypothesis. It has been proposed that low-grade septal inflammation may be responsible for dermal atrophy and that chronic inflammation may play a role in the fibrous septal development. Inflammation may also be a cause of the endothelial damage seen in cellulite. In pro-inflammatory states such as obesity and insulin resistance, presence of macrophages, Th1 cells, mast cells, interleukin-6, and tumor necrosis factor alpha can contribute to endothelial damage. A number of other factors may also contribute to the development or worsen the severity of cellulite. Aging negatively impacts the dermis and the fat lobules. Aging reduces the collagen and elastin content of the dermis. Fat herniation can increase at the subdermal junction through an atrophied dermis. With aging, there is also hypertrophy of fat lobules. Elderly females with a high BMI have the greatest risk of developing or worsening of cellulite. Improper diet and lifestyle factors may contribute to the development of cellulite or increase its severity. High carbohydrate diets and a sedentary lifestyle can lead to hyperinsulinemia and stimulate lipogenesis. Alcohol consumption also stimulates lipogenesis. Lipogenesis may result in an overall increase in body fat content, thus increasing the risk of developing cellulite. Summary: 5 reasons that cellulite forms. Toxic accumulations. Enlarged fat cells. Poor circulation. Fibrosis of connecting tissues. Water retention. Cellulite can appear regardless of body type or weight, says Marissa Garshik, MD, FAAD, a board-certified dermatologist at MDCS Dermatology. Though cellulite is not necessarily a sign of a poor diet or lack of exercise, Garshik says that these factors, along with genetics, hormonal changes, and dehydration, can contribute to its development. Exacerbating factors of cellulite. Genetics, weight changes, poor nutrition, lifestyle factors, poor skin health. Genetics. Genes may predispose an individual to particular characteristics associated with cellulite, such as gender, race, slow metabolism, distribution of fat just underneath the skin, and circulatory insufficiency. Diet. People who eat too much fat, carbohydrates, or salt and too little fiber are likely to have greater amounts of cellulite. Lifestyle factors. Cellulite may be more prevalent in Smokers, those who do not exercise, and those who sit or stand in one position for long periods of time. Clothing. Underwear with tight elastic across the buttocks, limiting blood flow, may contribute to the formation of cellulite. Grades of cellulite. Grade I, no cellulite is visible but early changes have begun. Grade II, no cellulite is visible when skin is at rest, but it becomes apparent when skin is compressed or muscles are contracted. Grade III, cellulite is visible when skin is at rest. Grade IV, more severe cellulite is visible when skin is at rest. The Nernberger-Muller classification grade evaluates skin at rest, either smooth, with an orange peel appearance, or having nodules, bumps, and depressions. Each of the 5 aspects is given a grade between 0 and 3, with 3 being most severe, and then the total is added up. 0 to 5 equals mild. 6 to 10 equals moderate. 11 to 15 equals severe. Cellulite has far more complexities than can fit within only 3 grades. How to get rid of cellulite.